Thank you so much, Giorgio, and I wish to thank our friend Vincenzo Sanicola for this kind invitation to take part in this interesting conference. So, locular surface disease is a pathology that we face probably not daily, but quite often in our offices, and especially in the practices or offices where we treat glaucoma. The question is, how frequent is such a disease in a patient receiving anti-glaucoma drugs? So what is the real cause for ocular surface diseases, and how relevant it is from a clinical point, especially to the surgeon who will have to decide whether and how to operate upon these eyes? As to the first question, many answers are possible. It is highly frequent, quite common, and severe symptoms are reported in nearly one-third of chronically treated patients, treated with anti-glaucoma drugs. All the ingredients of the eye drops commonly used might be the cause that has developed such a syndrome. To be sure, the zirconium chloride is the greatest or the main culprit, and also active ingredients such as ethanol, but even more, the prostaglandins have toxic effects, perhaps inflammatory effects. I say perhaps inflammatory because no, there isn't an agreement on this. And so the classical procedures, filtration, trabeculectomy, or deep sclerectomy, very often fail in these eyes because there is an aggressive fibrotic reaction of the conjunctiva tending to close the subconjunctival bleb that we try and produce. So problem here is the bleb. And we've been aware for a number of years, this is a paper dating back to 1990, that the success rate of trabeculectomy was significantly higher in the primary trabeculectomy group as compared with that in the multiple treatment group. And this means, in other words, that these chronic treatments are a relevant, significant risk factor for the failure of trabeculectomy, even with quite important metabolites. These are eyes being under treatment because they have a significant glaucoma, and after a certain amount of years, we cannot keep them in control any longer. So we are faced with the need to decide what surgery to opt for. So to answer to this question, we have analyzed a number of factors that experts are very well aware of. First of all, the kind of glaucoma that might be primary or secondary, or a pseudo-exfoliation might be opted for, and how long has the patient been administered anti-glaucoma drugs, and what's the residual vision in the subject, and what's the damage stage. How long did it take to develop, and what's the patient age and his life expectancy, and what is the intraocular pressure we take as a target, and the state of the lens, phakic, aphakic, and whether previous laser or other surgical treatments have already been performed. So to be sure, trabeculectomy is still the standard treatment. So we have to decide whether it is meaningful or sensitive to perform a trabeculectomy in these patients. Sometimes not. So if we decide that we want to go for it, we have to bear in mind that the post-op treatment, especially in the first months, probably is more relevant than the kind of surgery we opt for. in order to keep the bleb open. So this patient should be followed up by the surgeon who has operated upon him or her, or an ophthalmologist, knowing what to do depending on the stage and development of the disease. So when to remove the bridges, when to go for enabling, because otherwise the failure is sure. See if the eye is too inflamed to undergo trabeculectomy with some success, with some chances of success, we should opt for a different kind of surgery, i.e. by filtrating aqueous humor through internal ways, and we might use the minimal invasive glaucoma surgery, very often combined with phaco, but we must expect, we have to expect a minimum or a limited reduction of the internal of the IOP. Or if we might opt for an eye stent, or the SciPass that instead uses the scleral way that, or the scleral route that is quite difficult. This has been shown in several experiments in the past. So canaloplasty is not a minimal invasive treatment, but it works by increasing the drainage, by enhancing the natural outflow, I mean, through the episcleral vessels. And but the maximum reduction in the pressure we might obtain is 15, 17. Is it low enough? And then we can also use the canaloplasty probe ab interno, and microscopic guidance. We dilate the channel without touching the bulbar conjunctiva. And this can be also done with the gonoscopy guided or assisted transluminal trabeculotomy, and then stripping can be performed, and so we get 360 degrees trabeculectomy. And this can be easily done thanks to this new device that actually channel the viscoelastic and we have dispersion which is at least 50% of the circumference. So if we are confronted with a failed trabeculectomy, the breach is the scleral breach sometimes is anterior to the Schlemm canal, and so we may try a canaloplasty by which the canal can be cannulated, provided that this canal has been touched during the first surgery. And this can be done after inserting express before the Schlemm canal, and this has to be remembered. So on previously operated eyes where the surgery has failed, and certainly will have to drain, to resort to a drainage tube, or the new diode or a micropulse, the lasers may be used, or ultrasounds. Probably here the outcome won't be as good as with the diode laser. So we may conclude that, to be sure, the glaucoma surgery in eyes with ocular surface diseases is interspersed with a lot of difficulties and traps, even for experienced surgeons, and has a high failure rate. So we have to consider also possible surgery without subconjunctival filtration and canaloplasty in particular, touching upon an inflamed conjunctiva, but we are not interested because we are not aiming for a bleb, so we are not interested in scarring, and drainage should be used in particularly severe cases in expert hands, and here we have probably the greatest expert of tubes and valves, Professor Marchini. And the cycloablation should be considered as a last resort, because when all other ways or procedures might cause